Hello everyone, and thanks for joining us today. We are blessed to have Dr. Brooks with us for our final series of FluFIT, and so feel free to chat in any questions as we go along with the presentation. This presentation is pre-recorded just due to some scheduling issues. But I think that we will be able to still follow up with any individual questions that you have. If we don't know the answers, we will find them out for you. So I'd like to introduce Dr. Brooks. He has worked for the American Cancer Society's global headquarters since 2000. He's involved in the creation and implementation of strategies to improve the prevention and early detection of cancer and to reduce cancer disparities. A graduate of the Ohio State University and Wright State University School of Medicine, Dr. Brooks completed his internal medicine residency and chief residency at Wright State's affiliated hospitals in Dayton, Ohio. He completed his Commonwealth Fund Harvard University Fellowship in Minority Health Policy in 1999 and holds a master's degree from the Harvard School of Public Health. Before joining the American Cancer Society, Dr. Brooks practiced primary care medicine and served as the medical director in community health centers in Ohio and in his current hometown of Dallas, Texas. So welcome, Dr. Brooks, and take it away.
Certainly. Well, good afternoon, and thanks to all of you who have joined this. I'm pleased to be part of this series of webinars, and we'll provide wrap-up, sort of telling you how to really boost the likelihood of people completing screening once you introduce the concept to them through the FluFIT program. So this presentation is all about systems to support getting patients followed up all the way to the end of the screening process. So I'm going to talk about a number of different interventions that have been demonstrated to work in a variety of environments. Much of this is framed around a tool with which I hope many of you are already familiar, and that's the steps for increasing colorectal cancer screening rates. This manual was initially developed by the American Cancer Society and the National Colorectal Cancer Roundtable and geared toward improving colorectal cancer screening in the federally qualified health center environment. Safety net systems. However, we've learned that the vast majority of the information here is relevant to clinicians practicing in essentially any primary care environment. There are a number of important elements, but a primary piece of this that must be kept in mind: if you want to boost your screening rates, you need to involve the entire staff. Simply telling the clinicians that their rates are not good and they need to do better is not sufficient. It's really important that your non-clinical staff and your clinical support staff all understand your attempts to increase colorectal cancer screening, understand why this is important, and are involved. Everybody should have a role, and if everyone has a role to play and takes responsibility and ownership over that role, you will see some significant improvements. Everyone also needs to be kept abreast of the changes, the improvements that you're making, and their input solicited into what other sorts of interventions might be put into place in order to continue the improvement that you'll see once you get started with this work. Now, this is a graph that shows colorectal cancer screening improvements based on the number of screening interventions or new strategies applied. And as you can see, it's a pretty linear relationship, so that if you do one thing, you get a small boost. If you do 2 or 3 things, the boost continues to rise. There was actually a very recent study published just in the last couple of weeks that showed that combining high impact strategies like patient navigation plus patient education tools actually didn't just increase arithmetically, it multiplied the impact of those tools used together. So putting more interventions in place will help speed the increase that you see in your practice. Now, there are a number of important, very basic steps that have to be taken, starting with something as simple as how to collect the stool specimen. there is a study that is underway. Actually, the researchers have finished the data collection and will be reporting this very soon in the medical literature, demonstrating that the vast majority of specimen collection instructions that come with different kinds of FIT and FOBT kits are far too complex, complicated, and in some places downright confusing for many patients. And consequently, many centers have now shifted. This is one example of as you will see, a pictographic stool collection set of instructions, so that there is no reading required. And so this, therefore, obviously, other than a couple of small exceptions here, sort of eliminates the need for translation. There are also a number of videos online that have been demonstrated to be useful to help patients understand how to collect specimens correctly. One of the big problems that was actually identified by the same researchers was that in many practices, anywhere from 15 to 30% of specimens that are returned to the lab after the patient collects them can't be used for a variety of reasons having to do with incorrect specimen collection or labeling. So making sure your patients understand all the steps that they need to take, so if they go to the trouble of actually collecting the specimen and returning it, it can be used in your laboratory. Another important component of specimen collection is that it has to be done the right way. What I continually hear in my travels around the country and talking with primary care clinicians is that it's never the clinician that I'm talking to who's doing it, but they always have a colleague who is collecting specimens with digital rectal exam. So the patient's in the office, it's their expectation the patient's not going to return the stool specimen, therefore they're just going to do a rectal exam, and whatever they find on that glove, they're going to smear on a card, or they're going to stir it around in a bottle, and they will therefore say that patient is up to date with screening. Well, no, that patient is not up to date with screening. That is not an evidence-based approach to specimen collection. No study has looked at this using the fecal immunochemical test. However, a study that looked at the 3-day take-home collection of stool specimens recommended for guaiac specimens versus a single sample obtained at the time of digital rectal exam using a guaiac card, and looked at findings on colonoscopy among these patients. Of 2,000 patients had colonoscopies done, and prior to that had collected the specimens at home and also had a digital rectal exam specimen. Of those 2,000 patients, 21 were found to have cancer at colonoscopy. Only 2 of those 21 patients with cancer had a positive finding on the digital rectal exam specimen. So 19 of 21 cancers that were present at the time that the test was done were missed. Any test that misses 19 of 21 cancers should not be used in clinical practice. Again, there is no evidence at present that FIT testing performs significantly better, so digital rectal exam specimen collection is not acceptable or appropriate. The collection needs to be done as recommended by the manufacturer. Now, something that has been utilized now and is growing in use in a number of different places is in-office specimen collection, but it's collected in the same way that the patient would collect the specimen at home. They simply are setting aside a bathroom, and at the time that the screening offer is made to the patient is also asked, can you go now? And a surprisingly large number of patients, anywhere from a third to more than half of patients, oftentimes are ready to go give it a try right there. Now, in order to use this, which is called poop on demand, in order to use this approach, it's important that your clinic be using one of the fecal immunochemical tests that has been demonstrated to have high sensitivity with only collecting a single specimen. So you can't use a test that is recommended by the manufacturer to be analyzing 2 or 3 specimens. So it needs to be a single specimen test. And then the patient is sent to the bathroom with appropriate instructions and collects the specimen just like they would at home, only they never leave the clinic. And in every environment in which I've heard about this being utilized, there's been a almost instantaneous increase in colorectal cancer screening rates in those environments. So this is a reasonable approach, again, as long as the patient is collecting it in a fashion that's recommended by the manufacturers of that test. Another evidence-based intervention is the use of reminders, and reminders come in two flavors basically. There are education reminders, these are patient reminders, and there are education reminders, and then there are cues to action. An education reminder is a pamphlet or a brochure that educates the patient about why they need to be screened for colorectal cancer, or it can be a video, like these videos that are available on the American Cancer Society website in both English and Spanish. And this video we designed as a way to help patients understand the options around colorectal cancer screening and the importance of it without a physician or a clinician having to do all of that explanation. So it walks through each of the available recommended cancer screening tests and gives some of the benefits and potential limitations of that test, and also helps a patient actually see what happens during the course of a colonoscopy, for instance. So again, this is available on the American Cancer Society website in both English and Spanish. We also have a wealth of other patient materials and information that you can find on our website. The Centers for Disease Control, the National Colorectal Cancer Roundtable all have excellent patient education materials. We also, through the NCCRT website, have materials, template letters available for practices, because another element of the reminder, this is more a cue to action. And this is, you are now over the age of 50 and colorectal screening is recommended for you, and therefore, when you come in the office next time, we need to make sure we have this conversation with you to determine which test you want to use. Or in some instances, it's now a reminder that when you were in the office last time, we gave you this stool collection kit and it's not yet been returned, and we need you to send that back, and here's why. So we've created a number of these different templates that are all available in Microsoft Word so that you can customize them to the needs of your practice. You can put your logo, your address, the clinician's signature. So these are available for you to use at no cost, just download them. Now, in addition to patient reminders, a variety of different clinician reminders have also been found to be helpful and effective. Certainly electronic medical records, and particularly the registry functions or the reminder functions in some EMR systems, can be very useful. But unless your system has been customized to specifically address colorectal cancer screening, many out-of-the-box EMRs, frankly, just don't do a real good job. So if you have IT specialists or individuals in your practice who are willing to put in some time and effort, we actually have some tools and resources to provide a little guidance about how to optimize your EMRs for colorectal cancer screening. In addition, chart prompts, just something very basic. Whoever sees that patient at the front desk can determine if they are 50 or older, and if they are over 50, can ask the question, have you ever been screened for colorectal cancer? If the patient says, what's that? Or no, then some sort of a flag, either a flag in the electronic medical record or a little sticky on the paper chart, something to notify the next person down the chain that this patient needs to have a discussion and get some information about colorectal cancer screening. Problem list and integrated summaries are great if they are kept up to date. Also, an underutilized source of data is health plan data. Health plans have an incentive to have their patients up to date with colorectal cancer screening and are checking that data because it has to be reported into what's called the HEDIS system, which is a kind of a scorecard for insurance companies and health plans. So health plans can tell you which of their members that are taken care of in your practice they have screening data on. So simply asking your health plan to provide information to you on those patients in your practice on whom they do not have any colorectal cancer screening information is one quick way to identify folks who may need to be screened. Sometimes after you talk with the patient, you may find out that they had a colonoscopy before they were on that plan, or that for one reason or another the information did not get entered into your record, but they're actually up to date. But it gives you a place to get started with a certain pool of patients. It's also important to recognize that part of the reminder piece, though, is not just getting the recommendation to patients to get screened, but it is also imperative that patients are followed up so that if a colonoscopy appointment is made or if a stool kit is handed out, that there is a way to track and follow to make sure that that stool kit is returned or that the colonoscopy is actually completed. So there are a variety of different logs and tracking systems, and again, in some cases, EMRs can be helpful with this as well. This can be an ideal role if you have someone, a community health worker or a patient navigator in your office. It does require some staff time and commitment, but it also pays tremendous dividends. And these are a couple of the template tracking tools that, again, are available through the National Colorectal Cancer Roundtable and are referenced in that STEPS manual, the tool that I shared with you at the very beginning of this presentation. Screening navigation is another extremely effective approach to boost colorectal cancer screening rates. And this is basically assigning someone responsibility for making sure that patients who get that recommendation actually follow through, and to help patients problem solve to address any barriers they may run into. Navigator models vary tremendously. There are a lot of different approaches. In some instances, this is strictly phone-based navigation, where patients are, once they're given the appointment for a colonoscopy or given a stool kit, it becomes a responsibility of this navigator or community health worker to call them and remind them about the appointment, or if they haven't returned the stool kit, to call them and find out what's going on, or text or email, whatever works best for your particular patient. In other instances, the navigator may take a much more hands-on role. They actually assist the patient by calling and scheduling that colonoscopy appointment, by providing them with instructions about the bowel prep and walking them through that process, and again, reminding them about appointments. And then in some instances, it even goes further to the navigator making sure that the patient has transportation arranged, for instance, to get to a colonoscopy appointment, and if not, can assist them. So there are a variety of different things that can be done under the mantle of navigation, but the key element is having someone who performs that reminder function, who is a conduit to the primary care clinician office if there are any issues, challenges, problems, and someone to help the patient problem solve. There have been a number of different studies that have looked at screening navigation, including in very rural environments in rural Georgia. A navigation program there among very poorly educated patients found that by navigating patients, they were 4 times as likely to be up to date with colorectal cancer screening at the end of the study period. 4 times as likely. 5 times as likely to complete a colonoscopy. So this makes a huge difference in outcomes. And again, a number of other studies have looked at this issue, this phenomenon, and found navigation to be a highly effective approach. Electronic medical records I already mentioned in the context of reminders, but an EMR can serve in a lot of different ways to help boost colorectal and other screening rates. Both through reminders, as I already mentioned, through tracking and follow-up, and even helping to identify patients who are in need of screening. And as I mentioned, unfortunately, this potential is oftentimes not met, at least with out-of-the-box systems. The American Cancer Society and the National Colorectal Cancer Roundtable worked a few years ago with the National Association of Community Health Centers to look at what some of the challenges and shortcomings were for many out-of-the-box electronic medical record systems that limited their ability or their practicality as tools to help boost colorectal cancer screening. And Not surprisingly, there were multiple problems at multiple levels, some having to do with the EMR system itself, and this varied from one EMR vendor to the next, but all of them frankly had problems. It also had to do with staff training and resources, and then finally with other issues within the organization where priorities were placed. This report also, however, does point out a few high-performing systems and give some guidance about things that you can do regardless of what brand of EMR you happen to be on that can help increase the functions of tracking, follow-up, and identification that EMRs can provide. Some of the basic best practices include making sure that data gets put in the right place. One of my colleagues who works in a primary care practice actually had a small study done in his practice and identified a wide range of places in their medical record system. I believe he said there were 9 different places that they could enter information about a completed colonoscopy. But when they actually did data searches, information entered in only one of those places showed up. So they had a 1 in 8 chance of having the information in the right place. So simply standardizing, finding out, number one, where the searchable fields are, and then standardizing the approach that you and your staff make in putting this information into the record, you can potentially boost your screening rates without screening one additional patient, but just by getting the information in the right place. In addition, training, EMRs change, staff turnover, a lot of different things cause people to not maximize their use of the electronic medical record. Using EMR data to the degree possible to help with the follow-up functions is actually potentially much more effective at the follow-up and the initial identification of patients who are in need. Having data dashboards and summaries that include colorectal cancer screening, and then regular reporting of the colorectal cancer screening and other measures provided to you and your staff on a regular basis. We, in addition to the general report that I referenced earlier, we have recently worked with a set of super users of eClinicalWorks to create a much more detailed, almost step-by-step, screenshot by screenshot guide to improving or optimizing the capabilities of eClinicalWorks systems to track and measure colorectal cancer screening and serve as useful tools for boosting screening rates. We are now late in the process of putting together a similar guide for NextGen, and these tools, again, will be available on the National Colorectal Cancers Roundtable website. Another very important element to keep in mind is that colorectal cancer screening is in many cases, multi-step process, particularly if we're starting with something other than colonoscopy. If we're starting with stool testing, be it guaiac-based testing or fecal immunochemical testing, or if we're doing sigmoidoscopy or CT colonography, any of the non-colonoscopy tests have good outcomes, but those good outcomes are associated not just with doing a FIT test, but with making sure that there is appropriate follow-up for every abnormal FIT test, which means colonoscopy. So an abnormal finding on any non-colonoscopy screening test has to lead to colonoscopy in order for the impact of that test to be fully realized. This is modeling data from the U.S. Preventive Services Task Force. Many of you may be aware that they recently updated their guidelines for colorectal cancer screening to include a number of different tests. But this graph looks specifically at the use of annual FIT testing, annual guaiac-based testing with high sensitivity guaiac test, that is Hemoccult Senso. Flexible sigmoidoscopy combined with annual FIT testing or colonoscopy. And as you can see, they looked at the potential number of cancer deaths, so deaths from colorectal cancer that will be avoided per 1,000 individuals screened in a program of screening over 15 to 20 years. And they found that colonoscopy prevents 24 deaths from colorectal cancer for every 1,000 individuals screened. Stop and think about that for a moment. That is a huge, huge impact. That is a return on investment unlike anything that we see for most of what we do in medicine. 24 deaths averted for every 1,000 individuals screened. Now, on the other hand, if you look at FIT testing, it's 22 deaths averted for every 1,000 individuals screened. Now, is 24 better than 22? Certainly. Is 24 strikingly better, dramatically better? Not really. We're talking about a relatively small difference if the FIT testing is done in a high quality fashion. If it's done the right way, and this is imperative, every patient with a positive FIT has to go for colonoscopy to make sure that that is not related to a cancer or a polyp that may progress to cancer. So these kinds of outcomes are really impressive and strongly support the value of FIT testing, but it is, again, absolutely essential that everyone with a positive an abnormal FIT test or any other non-colonoscopy screening test have a follow-up colonoscopy. Unfortunately, what we have found is that there is non-completion of that follow-up colonoscopy in many instances. A couple of recent studies looked at this issue and found that up to 1 in 10 people with an abnormal FIT and 1 in 27 people with an abnormal FIT DNA or Cologuard test actually have colorectal cancer. So 1 in 10 who have an abnormal FIT have colorectal cancer. And up to 1 in 3 with an abnormal FIT have either cancer or a large polyp. So the opportunity to prevent cancer is still there in 1 out of 3 people who have an abnormal finding. And for those individuals with an abnormal FIT DNA or Cologuard test, 1 in 4 have either cancer or polyps. Now, a number of studies have been published in the last few years that look at the rate of follow-up colonoscopy for abnormal stool tests. And these have been focused almost entirely on guaiac-based or fecal immunochemical tests. And what they found is colonoscopy completion at best in the settings where they measured this is 83%. That still means that 17 out of 100 people who have an abnormal FIT or guaiac test don't get the follow-up colonoscopy that's recommended. And as low as 22%, which means basically 4 out of 5 people with an abnormal test in poorly performing systems don't get that follow-up. In a recent study from Fort Worth, where they mailed out a large number of kits, close to 10,000 FIT kits were mailed out. And of those, 25,000 kits were mailed out, nearly 10,000 were returned. Of those 10,000, 1,200 had abnormal FITs. They only completed diagnostic colonoscopy in 53%, so half of those patients actually got the follow-up colonoscopy. And based on that half, there were 12 cancers that were identified. Fortunately, 9 of those 12 were local cancers, meaning that those patients are likely have a very good outcome. And 364 of those patients had a potentially precancerous lesion removed. But this was only half of the patients who had abnormal finding, which means that you can guess that probably in that other half, there are 12 cancers and more than 300 polyps that have not been addressed. Another study looked at this same issue and tried to analyze the factors that were causing patients not to get that follow-up. And of over 2,200 patients that had abnormal FIT testing, again, 55%, so just a little bit more than half, completed diagnostic colonoscopy within a year of that abnormal FIT finding. Now, this varied a lot. The study was done across a multi-clinic network, 11 clinics total, and in the best performing, 75% of their patients, so 3 out of 4, but they still missed 1 out of 4 patients in terms of follow-up. In the lowest performing system, only 28% of those patients who had an abnormal FIT actually got their follow-up. And the median time to completion was 6 months. So it took 6 months for half of patients to get the screening done for them. And at 1 year, again, 44% of patients had no follow-up. And they had a lot of drop-offs along the way, so they tried to look at what are the different places where things drop off. And certainly a significant number of the patients drop off with the first step, that simply being referred to the GI. They never show up. But still, 87% of the patients who actually were referred to the GI got to GI. 87% of patients who had an abnormal FIT got a referral to go to GI. However, of those patients, only 65% actually made it to that GI appointment. And then only 55% ended up completing the colonoscopy. So there are problems at each step of this continuum that need to be addressed in whatever system you're operating in. But certainly, much of this starts in the primary care office, and that's why it is also imperative that we not stop following up and tracking at the point at which we make that colonoscopy referral, but that we continue to follow up with patients, both for a screening colonoscopy and particularly for patients who are sent for a diagnostic evaluation after that abnormal exam. So is failure to follow up really that big? This is another study that looked at failure to follow up, looking at it from a slightly different way, and determined that in this case, where again, over 40% of patients did not get a follow-up colonoscopy within 12 months. In this, 57% of the reasons were thought to be patient level. Either patients simply didn't show up, or they had transportation problems or barriers, they ended up in the hospital. So for a variety of reasons, the patients didn't show up. But also there were a significant number that were based on provider factors, that either the primary care or the endoscopist challenges at those levels kept people from getting screened. And then finally, there were systems level factors, some having to do with insurance or insurance coverage, some having to do with simply not mailing out appointments, and certainly not following up with when appointments were missed. So again, multiple problems at multiple levels. And this is kind of outlines in more detail a variety of the issues and challenges that were faced along the way that led to patients not getting their follow-up colonoscopy as required. So looking at a large number of studies that have examined this issue, there are a huge number of factors. Again, patient-related factors, including things like test refusal, but also barriers to colonoscopy that are commonly encountered. Not having transportation, not being able to afford the prep or tolerate the prep, the need to take a day off of work, having someone take them to and from the appointment. These are very commonly cited barriers in a large number of studies. There are also provider-related factors where, for instance, providers simply don't even recognize that an abnormal test result was found, and it just gets end up either being put in the chart or it's in the electronic medical record, and no one ever notices it. And then there's failure to order the required follow-up colonoscopy for one reason or another. waiting until the patient comes for their next visit, even though they have a positive finding on a FIT test, an abnormal finding. They just decide they want to wait until their next follow-up, and then for some reason or another, the patient doesn't follow up. Therefore, they never even are aware that they had this abnormal finding. And then there are health system factors with challenges to either scheduling colonoscopy or getting it completed, insurance issues. So a wide range of factors, and it's important for you to look at the system in which you are operating to try to determine whether any of these factors are impacting your patient's ability to follow your directions as it relates to both screening and follow-up colonoscopy. Now, okay, so we know that a lot of patients don't get that follow-up colonoscopy, but is that really important? I mean, how important is or impactful is having an abnormal finding on a FIT test? Well, a national screening program done in Taiwan looked at close to 60,000 patients who had an abnormal FIT, and 42,000 of them received colonoscopy follow-up. And then they followed this whole group of patients over time and found that the individuals who did not get a follow-up colonoscopy were much more likely to be diagnosed in the future with advanced stage colorectal cancer and had a strikingly higher risk of colorectal cancer death, particularly if you compare the non-completers, those who never got a colonoscopy, to patients who actually got a complete full colonoscopy. The risk of dying among those folks who did not get a colonoscopy was 2.5 times greater. So yes, that is significant impact. Closer to home, the study was published just in the last few months here in the U.S. Kaiser of Northern California Kaiser system has more than 30 years now worth of data on colorectal cancer screening. They have a very large, very aggressive, and extraordinarily well done colorectal cancer screening program. They are one of the model programs in the country for getting colorectal cancer screening done. They looked specifically at patients in their population from 2010 to 2014 who had an abnormal stool test, an abnormal FIT test. And among those patients, about almost 2,200 had colorectal cancer diagnosed. And they looked then not just at did they have cancer, did they have a follow-up colonoscopy, but they looked at the timing to determine whether it actually makes a difference, whether someone has a colonoscopy within 3 months or within 6 months or within a year. And what they found was a delay of 10 months increased the risk very significantly, both of colorectal cancer being diagnosed as well as increasing the risk of late-stage disease. So really the main thing to pay attention to on this graph is the bottom area here. And you can see that for individuals who had advanced stage disease in particular, if their follow-up colonoscopy occurred within 2 months, they were less likely, they had a lower risk. If it was done within 3 months, they had a lower risk of advanced stage disease. At 4 to 6 months, their overall risk was about on average. But if that colonoscopy was delayed for into 7 to 12 months, their risk jumped considerably. Matter of fact, it's almost double. And if it was more than 12 months, they had a 4 times greater risk of having advanced stage colorectal cancer. If their risk, looking at the section above that's labeled any colorectal cancer, their risk of developing any colorectal cancer was, I believe, about 2.3 times higher if the colonoscopy was delayed greater than 12 months. And again, the risk started to go up as soon as that 7 to 9 month period. So it really does matter whether, not just whether patients get a follow-up colonoscopy, but whether that colonoscopy is done in a timely manner. So it can't just be a matter of looking at whether patients finally get the test done, but your system needs to be designed to track, follow up, and encourage patients to get it done within a reasonable period of time. Now, this is actually from another study looking at a number of different relatively high-performing systems that have all put a number of different elements in place to boost colorectal cancer screening rates. The top two lines are the Kaiser system that we just talked about, and even in the highest rated, one of the highest rated systems in the country, in Kaiser, Northern California, you can see that only about 80% of their patients in this study actually got a follow-up colonoscopy within 12 months. Now, this is earlier data than the study that I've just shown you. Kaiser has put a number of things in place to try to boost that number. But in many systems, it is not uncommon, as I've shared with you earlier, for half of patients or close to half of patients who have abnormal findings on stool testing to fail to get follow-up colonoscopy. Now, there are, as I mentioned, a number of different reasons for this. There are also a number of different systems-level interventions that have been put into place, and this is really about changing systems. If you want to increase the likelihood of individuals completing their colonoscopy and doing so in a timely fashion, you have to put multiple interventions in place, and because this is, as I've shown you, this is related to patient factors, to provider factors, and system-level factors. You really need interventions at all those levels. So interventions that, for instance, automatically notify the gastroenterologist if there is a abnormal fecal blood test. So if your laboratory, if you are working in an integrated system, your laboratory should send that report not just to the primary care clinician, but that information should also go immediately to the endoscopy department, so that there are two opportunities to make sure that that gets followed up and tracked. Provider education around the issues that I've shared with you just now about the importance of follow-up and unfortunately the many gaps in getting patients followed up, and making sure that when information, for instance, on an abnormal fecal immunochemical test or other test is entered, that it can't just die or hide there in the medical record, but that it is flagged and that someone has to respond or act on that flag. Having very clear timelines in which individuals are scheduled for follow-up. So not just saying that every patient who has an abnormal FIT test needs to get a follow-up colonoscopy scheduled, but actually having a timeline. Colonoscopy should be scheduled within 6 weeks, within 2 months, and then tracking and measuring and reporting that on that performance. And that reporting needs to go both to the primary care clinician and build those teams, but it also needs to go to the medical officers, the chief medical officers involved in those practices. So there needs to be accountability at multiple levels of the system. Now, there are some physician or clinician-focused interventions that have been found to be helpful. And multi-component interventions, again, are much more likely to have impact. So not just clinician education on why colorectal cancer screening is important and on the potential pitfalls that I've discussed, but also putting interventions in place that either require documentation of follow-up and feedback. All of those things need to be part of the work that is done. And if you do create those sort of true multi-component interventions, you can have very significant increases in both screening rates and in appropriate follow-up of screening. Nurse navigator related interventions also can be very beneficial, in having a navigator or a nurse or another knowledgeable navigator involved in follow-up to do the sort of tracking, do the sort of patient reminders, and work with patients around problem solving that may contribute to them not completing their colonoscopy. Also has been shown to be very beneficial at increasing the likelihood of colonoscopy completion. For instance, this is simply one example of a nurse navigator-led program that was published based on work done in a Denver hospital, in a Denver safety net health system. So this is actually working with low-income patients who have multiple barriers, frankly. And the use of navigators increase the likelihood of completing colonoscopy after abnormal stool testing from 53% for those individuals who were not navigated to 72% with navigation. So a 20% greater likelihood, 19% greater likelihood of completing colonoscopy. Maybe you've noticed a theme running through my presentation, and that is navigation. Navigation is probably the single most influential thing that can be done with any healthcare system to boost both colorectal cancer screening rates and appropriate follow-up of abnormal findings. So navigation is key. Navigation is challenging at times. It can be difficult depending on where you live and what your systems are like to get navigation appropriately reimbursed, although there are some models. And actually the National Colorectal Cancer Roundtable recently produced a guide on reimbursement for screening navigation. So that again can be found at the NCCRT website if you're looking for ways to potentially bring a navigator into your system or increase your navigation resources. So again, this is the final webinar in a series related to FluFIT. This is the newest version, or a recent version of the American Cancer Society FluFIT program guide. We also are in the process of updating this, and will very soon be releasing a new implementation guide with some additional materials and some minor modifications. This can be found on the American Cancer website, and the new guide will actually be at this same web link. I also want to remind you that the program originated in San Francisco with Dr. Michael Potter. He developed the original FluFIT or FluFIT program, and he and his team also have a website with implementation, guidance, tools, and resources. And then finally, for those of you who are interested in learning more about colorectal cancer screening in general and evidence-based interventions, this tool was recently developed by the Centers for Disease Control, and this is an in-depth overview of optimizing colorectal cancer screening quality in primary care. This is available, or has continuing medical education credits available at no cost for a variety of providers, physicians, nurses, and other health professionals, and can be found at this link on the CDC website. And this will cover some of the areas that I've already touched on, but goes into much greater depth and detail about changes you can make in the primary care environment to boost your colorectal cancer screening rates. So thank you all for your interest in FluFIT, and hopefully all of you will be implementing highly effective FluFIT programs during the upcoming months. There is a wealth of material available on the American Cancer Society website beyond the resources that I've already mentioned to you, and resources available far beyond colorectal cancer. So for any and all of your cancer-related questions and needs for you and for your patients, I'd encourage you to visit our website, and good luck with your FluFIT interventions. Thanks again.